too. I know there's hundreds of questions. I'm delighted to welcome Dr. Matt Butler with us today. Matt's joining us for the second time, and Matt's first meeting that he had with us. It's been really helpful for many school leaders. I've had so much positive feedback because of the clarity around lessons from the health service that Matt's learned. It's actually got 60,000 views on YouTube now. So Matt, you've gone a bit viral. You're a bit of a poster boy in the teaching community. So thank you so much for helping us. So I'm going to just say hello to Matt, and if Matt could just say a little bit about himself, and then I'll introduce our two co-pilots of the meeting, Dan and Ray. Okay, Matt, just say hello and just quickly say who you are for the people who haven't met you before online.
Yeah, so hello everyone. So I'm Matt Butler, our consultant physician and geriatrician working at Adam Brooks Hospital in Cambridge. Today is my last shift, which I start just after lunch. Shortly after this meeting, I'm going to do my last shift on what was our COVID assessment unit at Adam Brooks Hospital. So I've seen the whole sort of peak through in the UK, looking after patients over the age of 16 up to the age of 98 presenting with COVID-19. And I basically got involved in this following a meeting at the school gates with Ray Snape, who told me initially it was going to be a handful of head teachers, and then I wasn't quite prepared for it to go to 60,000. But if you've seen that first video, that I want you just to remember that was released before the national guidance came out. So I'm pleased to say that, and you should take some succor from the fact that a lot of what I said has actually gone into national, well, not from what I've said, but it chimes with what I know with how the virus is transmitted and how transmitted and how effectively you can mitigate its spread within schools. So I'll pass back to Simon.
Yeah, thanks, Matt. Yeah, it did resonate and certainly got us ahead in terms of thinking about reopening before that guidance came out last week. So thanks so much, Matt, for your input last time. And please watch that video if you've not seen the two videos Matt did, an accompanying piece sharing his research and notes as well. Please watch that because it's incredibly informative. Today's session is designed to be Q&A. So we've had quite a few pre-submitted questions. I'm going to that I've grouped into different categories, but we are going to be using the chat function as well. So Dan, could you explain the chat function and how that works, and also the parameters around questions, Dan, that we spoke about this morning?
Thanks, Simon. Yeah, good morning, everybody. I'm Dan Thomas, CEO of the Learning for Life Partnership in Cheshire East. Please keep your microphones muted. There's a few going on and off at the moment, so just try and avoid turning your microphones on. Any questions, please do use the chat function, which you'll find at the bottom of your screen. Please, could we keep questions really to generic questions rather than specifics to your own particular site, because it is very difficult. Every school site is very different, so we do need to get general principles from today. I am recording this today, so if possible, we'll be putting that out as out on YouTube again. So if you don't want to have your face on a video, just please turn your cameras off. We've currently got over 300 people online with us. So back over to you, Simon.
Thanks, Dan. That's great. So I'm going to hand over now to Ray, and Ray Snape's our other co-pilot who's been involved in these since the beginning. Ray has the unenviable task of collating all the questions and curating the questions. So Ray, I see we've got 40 comments from the chat already. Are you here, Ray? I know she's having difficulty getting in earlier.
Hi.
Say hello, Ray.
Hi, I'm here, and I'm very proud to be the head teacher of Matt's children. And just to reiterate, when we saw the guidance coming out, I really felt that the co-construction that had happened through the Coroanacast had really fed into the DFE guidance. So it was really quite exciting and interesting to see that. So well done, Matt.
Thank you. And also, I think it's important to say that those sort of the things that came out from the unions over the weekend, there's nothing really in there, if we're following the guidance around best practice, that worries me as a school leader. So let's start off. Okay, Matt, so I've grouped the questions into three areas. The first one is around around the virus itself, COVID-19, and its impact on schools. So, and then I want to talk about the spread, and then I want to talk about hygiene. So we're going to cover a lot of things which are said already. So Ray, if you could monitor the chat, and if there's anything additional, we'll leave the last 10 minutes for questions. We are extending today's Coroanacast for an hour, so we will be finishing at 12:30. So with that in mind, I'm going to start off by asking Matt, in terms of anything you'd like to update us on, Matt, since we last met, and it was just under 2 weeks ago when we met on Bank Holiday Friday, when we met for the first time.
Yeah, so just a general overview on the position of the UK. So SARS-CoV-2 is definitely on the downward slope for both number of cases, but also number of deaths, quite thankfully. We still have around about 2,500 new cases a day, which we'll come to in a bit, but given that the largest study was in Australia, for transmission in schools, just to put it into context, Australia have had 7,000 cases to date. So in total, so we're getting 3 Australias in, we're getting 1 Australia in 3 days at current sort of UK number of cases. So that's just to put where we are on a sort of an international comparison. The virus, we're getting more and more information as to how it's affected children. And one of the specific questions was on this new disease or the new inflammatory state that's occurring post coronavirus. I'd just like to really emphasize that isn't a new thing. We've known for a long time that infections can trigger the body's immune response. That's how we fight infection. And unfortunately, in some individuals, probably due to genetic factors and also the sort of the infection factors, that they can also trigger what's called an autoimmune response. So when the immune system from fighting the virus starts to attack the body. And one particular syndrome that seems to be occurring quite readily in COVID is one called Kawasaki disease, which presents with similar symptoms to COVID. It just lasts a lot longer and is coupled with a rash. And specific features of tongue swelling and redness. That is quite a severe disease. It affects the blood vessels. But what I want to emphasize is that in any very common infection, so say flu, or if we had an outbreak of a different virus, it's very likely that you would get something similar. So the fact that is happening now is not to be unexpected. I think it is obviously worrying because some children are getting very sick, but it isn't out of the ordinary.
Okay, thank you. So we are seeing the the R rate. I mean, we most of the schools around are based in the northwest, and the northwest has had some quite high areas of outbreak. But in terms of the R rate and across the country, we're hearing reports that we're about 2 weeks behind London. In the northwest, but I am also hearing that the R rates are very much concentrated in hospitals, concentrated in care homes. So the R rate in the community across Britain, as far as we know, is below 1.
Yeah, so the R rate almost certainly in community settings, of which schools will be one, is lower than the average. So most transmission at the moment, as you've probably seen, is occurring in care homes. Care homes then import cases into hospitals, and hospitals then have their own transmission chains that they then need to quash. So the average number that you see for the UK being between sort of 0.7 and 1 is almost certainly going to be lower in community settings. When there is an outbreak, obviously in a local level, you're going to be more interested in what happens in your school. If you have no cases, then you don't actually have an R rate, because you need a case to have a discernible sort of thing to measure. So if you have an outbreak, if one child brings the case in and you get 5, your R rate will be 5. It really isn't really useful from a school's perspective to think about the average national R rate, apart from, say, on a local level. If you had your R rate go above 1, and then you found that some of those transmission chains were originating from schools, then that would obviously feed locally into what you do. But looking at the national R rate number, although it's very reassuring to see that the sort of the first peak is off the way out, isn't necessarily going to be helpful going forward when we exit lockdown and open schools up again.
Are there any lessons we can learn, Matt, from the health service and from the care homes? Because we know that that the highest rate of infection started in hospitals, then quickly moved on to care homes. So any lessons, because we're opening another institution here effectively by opening schools. So anything that we can learn from that institution to institution spread?
Yeah, so I think one thing to bear in mind is that this is going to be the new normal for a very long time. And anything that we do in schools, like we do in hospitals and care homes, has to be sustainable in the long term. It also has to be sort of emphasised that any actions that you take need to be reinforced regularly, and also just constant vigilance. So if you have a case in a school, acting on that and then acting on any potential contacts would be key to preventing it becoming an outbreak. And that's the only way that we're going to keep the R number less than 1 as we open up more schools. The difficulty has always been in hospitals and care homes, the asymptomatic cases where you don't actually know whether or not they have infection. Now we're solving that in hospitals and in care homes by starting, hopefully by 2 weeks, this will be routine, the routine testing of staff and patients. That if it became clear that that there was a problem in schools, that schools were setting up their own transmission chains, it would probably then expand to schools. I emphasize that would be dependent on there being evidence that schools are setting up their own transmission chains and are the epicenters for any potential infection. If schools are just importing cases from infected adults, i.e. their parents, and then no transmission chains are set up within schools on the basis of the evidence, then it would be unlikely that any national government would expend the resource to do routine testing in schools for pupils and staff, purely because when you've got a finite resource such as testing, you wouldn't want to necessarily expend it on that when you should focus perhaps on the higher risk areas. But that will be an evolving field as we go forward.
What's heartening actually is many of our schools have been open as care settings with numbers coming in. I'm aware of no outbreaks happening in the Northwest or wider. I know our nurseries have been open, and I'm aware of no nurseries that have opened. So that is heartening. It's anecdotal, but I think it is heartening that we have been open to groups of children up to 50, and we haven't seen that spread happening. In terms of testing, Matt,
and I think just to add to that,
yeah. Go on, Matt.
So I was just going to say, just to add to that, obviously at Milton Road, they have just purely been children of NHS workers in the main. So they're the higher risk settings. We know that healthcare workers are more at risk, and therefore their children are more at risk. Now that might just mean that I suspect my kids have already had it, because I think I got the infection fairly early on, and therefore they're not going to be infectious, but also likely to be immune. So I think that is heartening that the higher risk kids have already been at school and there hasn't been any outbreaks.
But you did mention on the first cast that the testing wasn't always accurate, and that you can have this disease and not test positive. So if we've got somebody showing the symptoms in school, a member of staff, for example, and then they test negative, should we still be encouraging them to isolate for the 14-day period?
Yeah, initially the advice was if you had a negative test, then you could go back. But the advice now is if you're still symptomatic, you stay off till you don't have symptoms, and that's irrespective of a positive or a negative test. So if you test positive and you've still got symptoms, you stay off till your symptoms have resolved. If you test negative, but you still have symptoms that fit with coronavirus, then you would stay off till you're symptom free, because we know that in the 3 days after you initially develop symptoms, that's when you're most infectious. So by the end, when you finish having symptoms, you're less likely to be infectious, even if you had it and you tested negative or positive.
Okay, that's great. I'm going to the next question now to talk about the spread, Matt, if that's okay. So thank you to Steve Alice, who submitted a string of questions when we asked for feedback on Twitter. So this is one of Steve's. What is the risk associated with staff being in a classroom with 15 pupils and one other adult? He's asked you to say, is it high, medium or low of picking up the virus?
So I'm very pleased to say that it's low for a number of reasons. So firstly, the transmission actually in the community, as we've already said, is very low. There's fewer cases out there than that are then setting up transmission chains, because most people that have had infection, it's burnt out in whatever setting they're in. So if they've been at home self-isolating, then, and even if their kids have got infected, the time that we've all been in lockdown means that that infection would have burnt out, and therefore even if they get released and go back to schools, that they then can't set up their own transmission chains, because by definition they're no longer infectious, for a number of other reasons. So actually on one of the research talks that I did, I actually showed that primary school children in some studies and in some modelling scenarios seem to have had the highest rate of infection, and I'll go on to talk about why that also is true when children are less likely to get it. But the fact that quite a lot of kids have already had it means that that there is an increased chance that if a kid is infected and that case gets imported, that the child that sat next to them is not going to pick up that infection. And it's key to any infectious disease that whatever breaks in the chain you can put in place, i.e. social distancing, frequent cleaning, or so-called herd immunity. So we're not at herd immunity levels yet, but having some immunity within a classroom does reduce transmission. And then going back to why children, because one of the questions I've had on Twitter was, I said in my first talk that children are less likely to acquire the infection, therefore less likely to get it, and then therefore less likely to spread it. Why is that? Why is that true when children seem to have the highest prevalence? Now, if you imagine adults can obey rules and children can't, so even before lockdown, children there was a greater opportunity, even though they were less likely to acquire the infection, for them to, so they were less likely to acquire it, but they were putting themselves in larger groups with more children, so the potential transmission events were higher. Now that's obviously key, because anything you can do, if you compared what your school was like pre and post lockdown, anything that you can do to reduce that will obviously reduce transmission. So I think because transmission is going to be low, because prevalence is low, the kids that are coming back are not going to be infectious from the start until transmission chains start to set up again. The risk to teachers is going to be a lot lower. Now, that's not to say that there won't be cases in primary schools. I think it's pretty certain that a head teacher or teacher that's on this chat at the moment will have cases within the school. It's how you then act on that to keep staff safe. So we'll go on a bit about what head teachers and what teachers can do to mitigate that.
Okay, and the guidance is that if you do get a case, then the whole class goes off for 14 days if we do get a confirmed case. So it is important, if people are showing the symptoms, that we encourage them to go for that testing. And then the antibody test is coming in, isn't it? We heard on the news this morning that the antibody test is getting quite close. Do you see that being rolled out into schools?
Yes, I think that specifically the Roche test with high specificity. So that's the ability of the test to accurately diagnose the condition and to rule it out. So if you have never seen the infection, what you don't want is the test to say that you have seen it, and that's the specificity. The Roche test is reportedly up to 100%. No, I never believe anything is 100%, but if Porton Down have said that it's as close to 100%, that is a very good test. It's important to differentiate this from lots of the tests that you can now buy. I think Superdrug launched one yesterday that are lower quality tests, and you've probably seen that you can buy those online. I wouldn't advocate people doing that because we do not know whether they're accurate, but also we don't know what they mean in terms of, yes, you have antibodies, but whether that means that you are immune is another matter. So I would stick with effectively what is going to be available from the NHS than going out and doing it piecemeal.
And they're going to start testing your workers, aren't they, with that? My understanding, the NHS workers. So there is a possibility that they could start testing teachers with that.
Yes. Yeah.
Yeah. Good. Okay, we got another question about any other symptoms we should look for. You've given a comprehensive list, which we'll share out later, so I don't think we need to go into that in too much detail. So in terms of the generations, Rachel asked this actually, in terms of that spread about age pairs. So can you just expand on that a little bit more from your last talk about the spread between people of a similar age or similar generation?
Yeah. So any infectious disease, obviously you can think about Legionnaire's disease or Ebola. There are epicenters, so there are situations where that infection takes off. Now in the UK, we decided to lock down fairly late, and there's a lot of evidence that when the peak of transmission was happening, so this isn't the peak of cases, this is the peak of transmission, which, given that there's a fairly protracted incubation period of up to anything for 2 weeks, that happened around the time that lots of adults were congregating in workplaces, but also in big sporting events such as the Liverpool Atletico Madrid match, and then also the Cheltenham Festival. Now, few children go to those things, so if you imagine all of those adults are cross-infecting other adults, it's not to say that adults can't infect children or children can't infect adults, it's just that adults socialise with adults and come into contact with them more. So those transmission chains were set up in older age groups in adults, and then all those adults, if they acquire it, they then by definition have to have an incubation period. The virus, you don't catch it and then immediately become symptomatic. We know that some people take around about 7 to 14 days. It can be a lot longer for people to become symptomatic, and it's only when you get symptoms that then you can isolate yourself. Because by definition, if you're asymptomatic, you have no idea that you've got the infection, but you could be infectious. So, so because of the length of time that it takes from acquiring the infection to you developing symptoms, and then obviously us entering lockdown, there just wasn't enough time for kids to be in schools and to be infectious, setting up their own transmission chains, because we'd already been in lockdown when they could have either been about to get infection or already in their incubation period.
Okay, so that's to do with the spread. Is there anything else, Matt, that you'd like to talk about around the spread before we move on to hygiene?
So I think it is key to just preface all of this with the on the science sort of talk I did, the short 10-minute one, that we really do not have huge numbers of data. I mean, only in this country have we been testing over 5s fairly recently. So as we get more data, we may be able to give you more answers. We will only get more data, obviously, if in a context where we have higher rates of infection in the community compared to Australia, that we actively collect that data from now. So it's just important to note that these are not, this is an ever emerging sort of evidence base. So we'll just have to keep an eye on where the infection goes, and also when we get in outbreaks, be they in schools or other community settings, that we then research and look into where those cases came from, adequately trace them, and then isolate all potential contacts.
Okay, some of our colleagues on the line work in nursery schools. So in terms of testing for under 5s, I think the advice currently is phone 111 if you suspect an under 5 has this. Anything to add to that?
Yeah, so I think I got that. I think that was, I can't remember what number question it was, but I did a slightly tongue-in-cheek answer to that. If you disseminate the thing a bit later, but if you've ever tried to do a swab yourself, you'll understand why doing it on an under 5 is going to be practically impossible. And there's 2 things about testing. So obviously, if you are testing someone who's potentially infectious, you are then at risk. So If you're then testing an uncooperative little individual, potentially you're going to be at more risk because they might fight you, they might pull off your face mask or your face shield. And the risk-benefit gain to testing those pupils would A, be too high, but also the gain to the under 5 is low, because they're not going to the law of averages state that they're not going to get severe disease. So practically, what I think you should do, and the reason they're saying 111 is, if you have symptoms, treat them as a positive case in the absence of testing, because I've already said the test doesn't pick up every positive case anyway. So the key to testing is not to say, okay, the test is negative, therefore the child doesn't have infection, that you would use that as an indication. So what we've been doing in hospitals is saying, oh, well, we're not sure whether they have infection, and then using that, if they have a negative test, to say, well, they probably don't have infection. If you've definitely got infection, actually, when we've had a negative case, as I said in the first video, we've been treating them as still having infection, so much so that we've put them next to other patients that have had COVID-19, because we've been sure that they've had the infection. And I think that same stance should be taken in schools, in that, which it is that if you are symptomatic, irrespective of what the test says, you should continue to isolate them, and then keep an eye on contacts. The value of testing is to know where the virus is, and therefore to be proactive in local mitigation strategies to control the virus, i.e. heightened contact tracing in those areas. What you don't want to rely on is testing on an individual basis. You will want to go with symptoms and local context.
That's really helpful. I think really need to allow us to extend our thinking if you've got a nursery school or if you work in an earlier setting. So it's important for developing those protocols and making it clear to parents coming in. Okay, moving on to hygiene now. So we've got some questions around hygiene, around cleaning. You gave us some great advice around cleaning different materials last time, that it stays on different things. So just recap on that, Matt, the way that it goes, and the virus can stick on certain surfaces longer than others.
Yeah, so any potential surface that could transmit infection, just to recap, is called a fomite, F-O-M-I-T-E, and that is the length of time that infection can live on that surface is dependent on the surface. So we generally think about sort of glass and smooth surfaces as up to 6 days, but say a week. So cleaning is vital, because in the absence of an effective vaccine or drugs, then cleaning and decontamination of an area would be key to stop transmission chains happening from infected surfaces. So one of the questions was, how frequently do you clean? There isn't a set answer to that. It obviously depends on potential that surface could be infected. Therefore, obviously, if you have a symptomatic child that's gone all around your classroom, potentially touching lots of things, then you need to treat everything as infectious at that time. If you have the general area where the tables are being used in a morning session, when the kids leave that table, it might be a good opportunity just to give that table a clean down. The light switch obviously is being, or the taps or door handles are being touched more frequently, and therefore you might sort of say, after so many contacts, that you want to clean that area, particularly the high use toilets areas, toilet seats, toilet flush handles, toilet doors, taps, that sort of thing. It's obviously going to be what's practical in your area, in your school, but I think generally adopting the principle of obviously not being OCD about it, but as often as possible cleaning those areas, because it may be that an asymptomatic case has come in, has infected that area, and obviously if you've got a regular cleaning schedule throughout the day for high contact surfaces, then that would dampen down any potential setting up of transmission chains.
Okay, many schools are telling me they're employing or redeploying additional cleaners into the school day, and they're also training their staff to clean as they go along, and that's been happening in many of the care settings with the enhanced hygiene that's been happening. So washing hands, we know that washing hands is a really good way of killing this, and hand washing is one of our first lines of defence. So you do recommend hand washing as children come into school with soap and water. Warm water is preferable to cold. I believe, because it goes go and break down the fat. So lots to think about how you're going to do your hand washing. And I think it's really important when we welcome children back into our schools. Many schools across the country are doing that in a phased way. So going from 2% to 50% seems quite scary for me. So actually, the schools are thinking about bringing in those children gradually so they can actually go and practice those best hygiene. But I think you mentioned here, Matt, about originally, if you haven't got additional hand washing stations, talking about having some troughs with a watering can, or having some a garden hose, because the weather's quite good at the moment. I wouldn't like to see children washing their hands in the middle of winter and those sorts of things. But I know that schools are thinking about the hand washing as a first line of defence with this. Got a question here about sanitizer, hand sanitizer or washing your hands with soap and water. What's the best?
Yeah, so they're equally as effective. You may find, certainly about a month ago, alcohol gel sanitizer was quite difficult to come by. But if you can get hold of both, it would be good to get both. There's pros and cons for each. So if you wash your hands continually through the day, say if you've got a child that's having to wash their hands 8 times, they're going to have to dry their hands 8 times, because drying your hands is key to stopping the child getting eczema. And if they get eczema, they won't want to wash their hands. So prevention is better than cure. So if you think about what I would suggest is hand washing at the, before and at the end of the day, and then before and after eating, and then potentially using alcohol gel sanitizer in between that, because then you don't need to wash your hand, you don't need to dry your hands afterwards. There's more opportunity for any hand towels that you use to get dry. But the key to both of those is making sure that each kid could probably moisturize their hands at least once or twice in a day. If you get a situation whereby pretty much all the kids in your class have quite bad, nasty eczema with sore hands, firstly, they're never going to want to go near the alcohol gel sanitizer. We had this, there was a meme that went through the NHS whereby there was a doctor that said, you never forget your first alcohol gel of the day. And then after that, it becomes less painful. But I've certainly, that first alcohol gel that you do in a day, and it really does pick up every single tiny little cut or scratch you've got on your hand. And a kid, just if they do that, they won't want to do it again. So effective hand washing at the start and at the end, and before and after meals, and then probably alcohol gel, because they can be fitted in more places without plumbing. Around the school. You don't need dispensers, you could just have the bottles, and then they could be either on tables or on sides and things like that. So I think using both in combination is the best strategy.
Okay, there's a great question here. Matt's given a comprehensive answer about, if you're a head teacher, what practical steps would you implement?
Simon's paused.
That's safe. Are you there? Yeah, Matt, can you hear me? Yeah, so great question here about what, if you were a head teacher, what practical steps you would take to implement. I'm not going to ask you to answer that because you've written a comprehensive answer, but I think the big one, as we start reopening our schools, Matt's put no more staff meetings in person unless strict distancing is in place, and preferably, if you have to do that, meet outside. We're all good at this technology now, so I think we need to absolutely minimise the contact between adults, and that's a great tip. There's some good stuff on there. So I'm just going to move on quickly before we move on to the questions with Ray. Classroom bubbles is the concept that I think head teachers have never talked as much about bubbles as they have this week. So this question about how stringent should we be in classroom bubbles, about not having other adults coming in and out of them. And one of the challenges I've got, Matt, is opening my before and after school care as a head teacher, because I know that some of my frontline workers absolutely rely on that to go to work. So I'm specifically around the contact with other adults and what we can do if we are going to open before and after school care.
Yeah. So I think, given that this is going to be a marathon, not a sprint, with regards to sort of bubbling, effectively, you want to, if you cannot avoid your bubble being broken, say by after school care, trying to recreate the bubble as much as possible going forward into that after school care. So, for example, within presumably actually quite a lot of parents that had kids in after school care before lockdown, they may not well take up after school care after lockdown because of their work has moved more to home. They may opt to put themselves at lower risk by allowing their child only to mix with their classroom. So I think the numbers that are going to go to after school care will be fewer. But if you can replicate the bubble, so for example, when you go back on the 1st of June, if that's when you do, you'll only have 3 year groups. Presumably, of those year groups, you may only have one class of the 2 or 3 at any one time, and therefore, if they were to go to after school care, there will be only 3 potential bubbles moving into that after school care. If you then could recreate those bubbles in that, i.e., could the after school care be done in a large area whereby the kids can be segregated, or could you have after school care whereby the class bubble is maintained, or family bubbles are maintained, because your bubbles will be broken every time a kid goes home. The reason for bubbling is to reduce the likelihood that an infected case comes into contact with many other people all at the same time, and then that infected case can then go and infect another group of people. It's not necessarily to stop transmission chains, because a transmission chain can still be set up within the bubble. That will then go home. Potentially an older sibling or a parent could catch it, and then they could take it to work or a different school or a different classroom. But what that does do is it allows a delay, because obviously there's an incubation period of between sort of 5 to 14 days. It does allow a delay where then you can act. So I think when it comes to after school classes, if you can take mitigation strategies to maximize the continuation of the bubble, and another way would be, if there is obviously the adults that are running that after school care, they could potentially be infectious, but you could, as a mitigation strategy, say, we know that face coverings prevent the vast majority of transmission from asymptomatic cases, because if they're symptomatic, they won't be supervising children. So you could mandate that anyone that's running after school clubs wears a face covering in order to protect the ongoing bubble. So although there is a different adult that's taking care of that bubble, then they're less likely to bring infection into that bubble. And I think going forward, it depends really on the prevalence rate for infection. So if we continue to keep the R number well below 1 in schools, as time goes on, the need to be so strict and stringent in these measures with bubbling will come less and less. Obviously, outbreak, you need to go and become ever more cognizant of what's going on in your school and enhance the bubbling. But as we come through this pandemic, and obviously then hopefully in the future get vaccines where we can proactively vaccinate potential contacts, then the bubbling becomes less and less important. So I'd see it as a...
I've just lost Matt. Has anybody else lost Matt? Or is it just me?
Oh, lost him as well.
Yeah, a few have lost him. Okay, so I'm sure he'll come back, because that's what goes and happens with Zoom. So I'll just pick up on that from Matt on before and after school club, because I mean, one of the guidance, the government guidance says if we are going to offer that wraparound care, then to go and have the stringent social distancing between those groups as well, because we do know that it's not going to be it's not going to be possible. So Ray, I'm going to hand over to you now, and I'd like you to ask some questions, easy ones that me and Dan might be able to answer, or yourself, and then hopefully we'll see Matt reappearing. So nothing too technical that you need a degree in Cambridge in medicine to answer, just something for a primary school head teacher.
Okay, so just to continue the conversation about bubbles, colleagues who are thinking about, so we've got parents who are saying, I'm not going to send my child to school full time. I only want my child to be in a bubble 2 or 3 days a week. What will the effect be, do we think, on the bubble?
Well, I don't
So-
see that as a... Go on, Dan, did you want to answer that?
That was Matt coming back, actually.
Oh, is that Matt
So,
coming back? Matt.
No, Dan wants
Matt?
to answer that.
So,
Oh, we're taking the view, and Matt might be able to jump in and tell me I've got the wrong approach here, so that's absolutely fine. We're taking the view that the children are going to be in the bubble, and if they're accepting a place, they're going to be in for the whole time. We're not having children coming in on part-time basis as a rule, where they come in for a couple of days, miss a day, come in for a couple of days. Part of that is around how we actually administer this and how we keep everybody as safe as possible. So partly it's practical around our staffing, but partly I think we've not got guarantees about social distancing at home. And, you know, actually if we're keeping the children in the bubble, the more time they're in that bubble, the better it is for us, I think.
yeah, I'm taking a different approach,
Same
actually.
here.
Dan, to you, I'm actually, if people go in part-time, I mean, we can't really control what goes on out of home, but the bubble will stay. The bubble will be limited at 15, and some people might just be in for 3 days a week. So I'm taking a slightly different approach there. So I want to bring Matt back in, because just before we open up the questions for Matt, Matt, face coverings. Last time we met, we talked about the concept of face coverings, and I know some head teachers have been thinking about just trialing them in year 6, but the government guidelines have said we shouldn't be doing it as common practice, because young children can't take them on and off safely. I know that some manufacturers, some of our parents, is making cloth face masks for the NHS. So if we do decide as school leaders we're going to trial face masks for the children within a setting, how often should they be changed? How should they be taken on and off? And what's your view 2 weeks later on face coverings within a primary school?
Yes, I think the face coverings definitely prevent or reduce the risk of transmission from asymptomatic cases. The difficulty always is with face coverings. If you imagine you're wearing something over your mouth and you're breathing in through such a confined space, effectively what you're doing is you're filtering all the environmental air onto a very limited surface. And therefore, it's vital then that the kids can take them off properly. And the easiest way to do that would be to have elasticated straps around the ears and to tell them never to touch the front. So we have this, the face masks with the blue outside. And once that goes on, we absolutely do not touch it. And we only ever go to the back of the head and then take it off, and then take it off. And then if it was a cloth face covering, you would then fold it in half, outside in, so that the bit which is closest to your face is now on the outside, and then you would put it in a plastic bag. That is going to be very different. I've seen it. Staff members attempt it in the NHS, and when we were getting down to low numbers of masks, it was advised that the health and safety executive said that we could revert to that if we had to, if we ran out of masks, but it's not ideal. So I think if you were confident that the older children could do that properly, and year 6 might be able to do that, you would have to drill them to do it, and you'd have to be confident that they were doing it properly. But if you were confident of that, then if there was an asymptomatic case, it would reduce transmission. You may opt to do this in the case whereby you've had a case within the school, you've had the 14 days for that classroom to isolate, and then say in the next 2 weeks, because we know that some people could potentially have a longer incubation period, you may say that you want to do heightened measures such as face coverings for that period, perhaps up to a month. But there is no real hard and fast rule, because there's no hard and fast evidence within schools. And what we do know is that on the New South Wales data, that transmission within schools is likely to be low, and then therefore any mitigation for transmission is going to have less of an impact. So if you've already got a low level of transmission, doing something to reduce that transmission even further may have an effect, but the effect is likely to be very small. If you're in a high transmission area, so public transport, the tube, it makes more sense to wear face coverings.
Okay, that's helpful. It's something updated on that. And if they were to wear them, how often should they change them?
So the advice would be that one person has it for the whole day when they're in them, say, outside, that it goes into a plastic bag and then they're washed at the end of the day. Okay. So ideally you'd have maybe 5 per child if that was the case, and then they'd wash them at the end of the week, so you didn't have to do a wash every day.
Okay, final question for me, then I'll hand over to Ray. So we had Jan de Beer on, who's an early years expert, and he was talking about the Danish model. They are cleaning resources on a 24-hour cycle. However, our guidance says we only have to clean resources between bubbles if they're sharing resources. So in terms of cleaning, I mean, Jan said that the Danish nurses are using washing machines at 80 degrees to clean those things. Would buckets of hot soapy water be suffice if we were to go and have to clean some of our construction materials, for example?
Yes, are you talking about things like wooden blocks and those sorts of things?
Yeah, wooden blocks or Lego, but it says between. Yeah. I mean, this is between bubbles. The cleaning.
So I mean, the Danish model is better than say within bubbles, because obviously if you have a case within the bubble and you've got 15 pupils, if you don't clean within the bubble, then potentially those 15 are going to be exposed. It's just that on a national level, it makes less of a difference, because if you've got a case which then turns into 15 on a school population basis where you've got tens, if not hundreds of thousands of pupils, it doesn't make that much difference sort of nationally, but it does make a difference within your school whether you've gone from sort of 1 case to 15 cases. So so I personally think as much cleaning as possible. Any cleaning is better than no cleaning. Obviously, the higher the temperature and the sort of the more abrasive the detergents, the more antiviral the detergent that you use would obviously kill more virus. But the vast majority will be just expected to be cleaned out by sort of simple soap, detergent and warm water. So you would get rid of 90% just for argument's sake of infection that way. And then the 10% is as you increase the temperature and increase the antiviral nature of the stuff. But it might only be that you need 90% because the prevalence is so low and the contamination is so low.
Excellent. Okay, I'm going to hand over to Ray now. And Ray, if you could start curating the over 100 comments we've had in the chat.
Yep, so some of the
13 minutes.
Okay, some of the questions we covered almost within the conversation about bubbles, but a question here about if a child is sent home with symptoms and we have to wait 48 hours for a negative result or a positive result, what should happen to the rest of the bubble? How are we going to manage parental expectation or parental concerns while that child has been sent home?
I think that's an individual school's choice based on your risk assessment, really. I think you need to make it clear to parents what you're going to do if that's the case, but I wouldn't like to give blanket advice on that, because that'll vary from school to school, and you'll have to communicate that with your parents.
And it is about confirmed cases and then the rights of people not to have information shared about them. So another question, which is, you said earlier on, Matt, about we're going to have to get used to this. This is not going to be a quick thing that's going to disappear. So what's the, has there been any modelling on the new R rate, and will there be a second peak at some stage?
Crystal ball time, Matt.
So I don't need crystal ball, because the Imperial College, where I didn't go to university at Cambridge, I went to a better medical school at Imperial, just for argument's sake. But the modelling at Imperial College says that when you reduce lockdown measures, that it's highly likely that we will get a second peak when influenza season kicks up again, because COVID is indistinguishable from influenza. We're going to get loads of flu, and therefore the cases of COVID are going to slip through the net, because it's we know with flu, although children aren't super spreaders for COVID, they are for flu, and therefore they can still get sick from flu. So it's going to be very difficult in winter time. And I think all of our strategies before then are going to be as a dress rehearsal for winter, because I think that is going to be the real challenging time, both for the NHS, the care sector, and for schools. I sincerely hope that we don't have a second peak, but I think as the ever sort of pessimist in our household, I think you all just need to prepare that there will be. And then if it doesn't happen, it doesn't happen. And we've built all these Nightingale hospitals, and you've washed a few more things than you would have done. But overall, no one's lost anything.
And going back to what we were talking earlier about resources and the things that the children will be playing with, some questions around what's going to happen with outdoor play equipment, sort of wooden play equipment, and whether that will be safe for a bubble to use, or whether they shouldn't use it at all.
It'd be helpful, Matt, if you talked about outside equipment, because outside equipment may be the virus may get eliminated quicker.
Yeah, so there's definite evidence that exposure to direct sunlight does degrade the virus quicker. Also, because it's in a more drying environment, and the surface that it's going to be on, either wood or something like that, is going to be less likely to harbour the virus. And also, if you imagine you're a child, you're breathing, you're coughing, and the wind will take the most of that away. So there's less chance for it to settle on outdoor play equipment. Obviously, if you've had a child that's come into school, has played on something, and then turns out to have symptoms and has been coughing around that, then obviously that's a little bit different. But in the general case where, yes, we're going to have asymptomatic transmission, it's going to be less likely that a fomite is going to be formed outside, firstly because the virus isn't going to be living for very long, but also because the wind is likely to have taken that virus away, and the dispersal and the deposition is going to be at such a low concentration, also because play equipment's a lot bigger, that even if a child and a virus was on that surface and a child picked it up, it may not be that there's enough virus on their hands to then cross-infect themselves. But that's key, obviously, when kids come back in, before they get back into the classroom, where potentially they could then touch other things, that they then wash their hands.
So if we go and keep the play equipment for each bubble, and then let's and then clean down the hard surfaces overnight, but the wooden surfaces we should be okay in terms of that. So I think that's sound advice there. Okay, Rick.
Okay, this is a new one on me, and it's called fogging machines or foggers. Colleagues talking about in early years where there is a steam cleaner that is being used. I don't know if anybody else has some, or you know about this, and the benefits of using a fogging machine to get rid of the virus.
So we don't use them in hospitals when we've had confirmed cases. We do use them for things like C. diff, because C. diff spores are quite they're quite pervasive. They last in the environment for quite a long time. But the virus, we use something called Acticlor or to clean, and the virus is a clean compared to bacteria. So the current advice is that you don't need to. This is WHO and DFE advice that you don't need to use fogging machines. I think that the danger of doing anything that's OTT, over the top, would be that then you are less stringent on the wiping. Fogging obviously works if it gets into every area, but if it's a big classroom, there will be areas in drawers and things like that the fog doesn't penetrate, and surfaces that it doesn't reach, just by the nature of the fogging machines. So often in a big place, in a big room, we would have to have maybe 3 fogging machines. And it's also key, obviously, when you're fogging, that you then seal up all the gaps, because otherwise it's all just going to leak out. And I think that's impracticable in schools. In hospitals, we have sort of specialist sort of supports that we can cover ceiling vents, and the windows and the doors are taped shut. But that's just going to be impractical in schools. So I think just go with the advice, just cleaning with the set solutions. I can't remember
Thank
the
you.
concentration, but it's Actichlor, I think, is what the WHO advised.
So just a couple of questions, probably the last ones from me. Going back to the data and the research, you said earlier, this is a question from Michael Rogers, you said earlier that there are thousands of new cases. Given that we don't quite have track and trace in place, is there an understanding of where the thousands of cases are more prevalent? Do we have an idea of which people are more at risk?
Yeah, so unfortunately, the biggest places, as a geriatrician, it sort of pains me to say, but the care homes are the major sources of infection and reinfection, and they are still going to be locked down. Certainly, if there were children that were visiting care homes, you should see them as high risk. The second, just by the nature that people in care homes that get sick then come into hospital. The second, so most prevalent area for transmission is hospitals. We know that 20% of cases within hospitals are acquired within hospital. So that just goes to show how much infection there has been. That's probably a lot lower now, given that we're coming out of this for the first phase. But certainly schools, I wouldn't see anywhere near at that level. In fact, given the low likelihood of the low prevalence, you're already going into this in a very good situation. So long as an effective track, trace and isolate system was in place, and obviously it's up to you whether you feel that is adequate before you go back. But if that was in place and you could effectively isolate cases as they come in, I think what because that's effectively what the New South Wales data showed, was that when a track, trace and isolate strategy was in place, no teachers got infected. So long as you're happy that we have an effective system as they had in place 2 months ago. When was it? March, April? Yeah, a month ago, two months ago in Australia. If you're happy that we have that same system in place, then you can be happy as well that then would replicate that same scenario. The virus hasn't changed so much between now and then for it to be more infectious to teachers.
Okay. So Simon, I'm mindful of the time and it looks like we've got 3 minutes.
Yes.
One more question?
Yeah, so I think Steve Alice has just put something on the chat there, and I suppose there's a lot of things around the reopening on the 1st of June. I've mentioned earlier that it's the 1st of June should be a staged approach, and it is an ambition of the government. The government could say as late as the 28th of May that they've decided not to. But I think in terms of the steps we've been talking about with you, Matt, over a couple of meetings and the things that schools are trying to do, would you kind of concur with the government that it's the time to start expanding our numbers in schools?
Yeah, I think for a number of reasons. So I think all the evidence points to, particularly looking at other countries that have either never closed schools or have closed them to some extent and are now reopening or have now reopened. The evidence is that it is it's not risk-free. You will have cases within schools, but the risk is low enough to no longer justify the continued closure of schools. Schools have a huge positive impact on society. For if you think of sort of the life chances of the individuals at the school, we're probably now at a point whereby a lack of education for those pupils is going to then impact on them from now, if we do not get back to education, educating them. And also I think now that we have more tracing, and hopefully by the end of this month we'll have up to 200,000 tests a day if the government meets its target without just simply posting lots in the by Royal Mail. If we get up to that target, we should be able, given that we have 2,000 cases about every day now, by then we'll have so few cases that we should be able to then track where it is, isolate all those cases and trace their contacts, and then test all their contacts and ongoing testing for their contacts. And if you had an outbreak in a school, I think the full you didn't know where the indexed case was. I think what PHE would then do would be to test everyone, because it's bound that there will be an asymptomatic case that would have set up that transmission chain. And I think now we're in a much better position to do that. Obviously, you're not back yet, and no one's tried out the new system. No one's got many 5-year-olds to go and get tested because they haven't been infected as yet. So it would be key just to keep that under review.
Excellent. Well, perfect timing. That's taken us up to the hour. So Matt, thank you